enough able to take orally. During this time, we will be given heparin, low molecular weight heparin, or unfractionated continuous unfractionated heparin.
Is it evidence-based answer?
Sir, actually, I wanted to know the
question was
implication.
not this.
Yes,
The question was not an easy question, and the answer may be even difficult to answer. I think the situation may not be so common. Number one. Number two, I think if the situation is so, you should give recombinant tissue plasminogen activator, that is reteplase, irrespective of the warfarin dose.
Yes, sir. Yes, sir. I was expecting this, sir.
But why are you asking such complicated question? Your question is so tough that the presenter even could not appreciate your answer. Your question.
Sir, actually, sir, I went through this question, sir. A senior teacher asked me this question, sir, a few days ago. Sir, I know the answer, sir. Can I, sir, share this, sir?
Sure.
Sir, actually, if the patient is getting anticoagulation, sir, and if the INR is greater than 1.7 or the prothrombin time is greater than 15 seconds, sir, in that case, recombinant tissue plasminogen activator cannot be given. It is a contraindication. In that case, we should go for mechanical thrombolysis or thrombectomy. But if the INR is less than 1.7 and if the prothrombin time is less than 15 seconds, and recombinant tissue plasminogen activator can be given within 3 hours, sir. But recombinant, if the patient is not getting anticoagulation, recombinant tissue plasminogen activator can be given up to 4.5 hours. But the time limit is up to 3 hours if the patient is getting anticoagulation and whatever the INR is.
General consensus is that the time limit, that is the cutoff for time for administration of reteplase, is 3 hours from the onset of acute ischemic stroke.
Yes, sir. Yes.
In general, I am not just telling about the patients receiving warfarin or not.
Yeah. Yes, sir. Thank you, sir.
Welcome.
Dr. Imtiaz, another, actually your question is very much pertinent. And another question, I think when you are approaching your question, I think you will give a scenario of having hemorrhagic stroke. But
sir, actually, I have excluded hemorrhagic stroke by CT scan. I have told that, sir. And the patient is not having a hemorrhagic stroke. A CT scan was done, and hemorrhagic stroke was excluded, sir.
No, if the patient having hemorrhagic stroke.
Yes, sir. Yes, sir. Then
how will you approach? This question is to you.
Sir, in that case, sir, anticoagulant should be immediately stopped, sir. And if the patient is having mechanical heart valve, sir, in that cases, no more than 13 days prior, the anticoagulation should be started. The general recommendation is to start anticoagulation after 2 weeks. But in some high-risk cases, after 6 days can be started. And those high-risk cases are patient with concomitant atrial fibrillation and patient with mechanical heart valve in mitral position and patient having mechanical heart valve with older generation heart valves such as ball and cage heart valves. In these 3 situations, anticoagulation should be started after 6 days. And in all other cases, anticoagulation should be started after 14 days at least, because starting anticoagulation prior to 13 days will increase the risk of hematoma enlargement and will lead to further deterioration.
Yes, and if feasible, the site of intracranial bleeding should be clipped or coiled.
Yes, sir. Yes, sir.
But if without clipping or coiling or any other interventional therapy, we have to start after 6 days. The scenarios you have mentioned. What is the reference?
Sir, the reference is from a journal from ESC, sir.
Yes, there is a guideline, and it is the worst situation where the earliest can be started anticoagulant. 6 days or 1 week, just at the end of 1 week, after 1 week.
Yes, sir. Thank you, sir.
But usually after 4 weeks and maybe after 2 weeks, This will be based on the urgent nature of the condition.
Yes, sir. Sir, and there is an option, sir, LA appendage exclusion if the patient is deemed too unsuitable for anticoagulant therapy. It is a class 2B recommendation, sir.
We are expecting question from the cardiac surgery fellows. Cardiac surgery fellows?
Speaker, अपना screen share off करें. Presenter, please off your screen share.
Sir, assalamu alaikum. Sir, can I ask a question?
Yes, you can.
Thank you, sir. Thank you, presenter, for your nice presentation. My question: if the patient is hypothyroid simultaneously and he or she is taking thyroid hormone, then what is the effect of thyroid hormone on warfarin?
Okay, thank you for your nice question. Yes, in case of thyroid disease, in case of hyperthyroidism, there is a high level of clotting factor turnover. The clotting factor turnover is high, so the prothrombin time will increase with warfarin use. And in case of hypothyroidism, the clotting factor turnover is low, so there will be decrease in warfarin effect in case of hypothyroidism in with warfarin. Did you get the answer?
Thank you. I have another query for from your presentation. That would you please enlighten us how warfarin necrosis occurs?
Oh, okay. Thank you for your another questions. Warfarin necrosis usually occurs during the first 2 or 5 days after using the warfarin. During the time, there is a procoagulant activity caused by the warfarin, which is caused by the inhibition of the protein C and the protein S also. That's why there will be a hypercoagulable factor, and there will be warfarin necrosis occurs in different area. And the warfarin necrosis usually occurs in breast and the fatty tissue in where the fatty tissue is bulk abundant is present, such as breast, abdomen, and the thigh also.
This is very important. And you know that protein C and protein S is at first inhibited and at a lower concentration of warfarin in blood before the other clotting factors are being inhibited. So during the time interval till the achievement of the blood level for the inhibition of the blood clotting factors, you have to ensure protection by giving subcutaneous or parenteral anticoagulants. Because protein C and protein S is inhibited first. That is why there is a procoagulant stage.
Thank you, sir.
Any question or interaction from the faculties?
Assalamu alaikum, sir.
Yes,
Assalamu alaikum, sir.
Walaikum salam. Ask your question.
Sir, I'm Dr. Manjurul Hassan, sir, Phase B resident cardiac surgery. I have a question, sir.
Yes, please.
Sir, we prescribe warfarin in different conditions, but I have a question. What will happen if we prescribe warfarin in pregnancy? And usually which substitute we use?
In case of pregnancy, thank you for your nice question, Manjur bhai. And in case of pregnancy, we usually avoid the warfarin during the first trimester, and also in the last 3-4 weeks of the before delivery. If we because if you use warfarin in high dose, there is a high chance of causing warfarin embryopathy, which is known as Disala syndrome. And therefore we try to avoid warfarin. If we are unable to avoid warfarin, we can give it in a low dose, less than 5 milligram, so that there is a less chance of having any warfarin embryopathy. And we should use other drugs such as low molecular weight heparin during the time of pregnancy, if there is any thromboembolic manifestation. And we can also use low molecular aspirin in a low dose also. Have you understood your answer?
I think he has answered nicely. Actually, the current consensus is that you should better avoid warfarin during all stages of pregnancy. But if you are compelled to prescribe warfarin, of say a patient on warfarin just got pregnant inadvertently, and ultimately what to do? If the dose is within 5 milligram per day, there is very low chance of warfarin embryopathy. So you can continue the dose up to 5 milligram per day, even during the first trimester of pregnancy.
Yes, sir.
And another thing is that what is the mechanism? Just along with the inhibition of the synthesis of clotting factors, this warfarin also inhibits osteocalcin, another protein. And this osteocalcin is needed for synthesis of bone.
Bone mineralization.
Osteocalcin is just inhibited, there is impaired formation of bone, ultimately leading to the congenital anomalies involving the deformed bone or the impaired bone mineralization. So, warfarin embryopathy occurs. So you have to better avoid this, and if you are compelled, the dose should be within 5 milligram per day.
Thank you, sir.
Hello, sir, I'm Dr. Charias. This is a very, I think, very enlightened issue that you have projected through your presentation. Thank you very much. So, can you give us some idea about warfarin diet, doctor?
Yes, I can, sir. During while prescribing the warfarin, patient should be adequately counseled about warfarin diet. The patient should avoid green leafy vegetables such as cabbage, spinach, lettuce, greenberry juice, liver of animal, and they should avoid this kind of food also. And they can take other vegetables and also orange juice. And the patient also should be avoided patient should also advise to take it and during the time of in the evening at 6 p.m. While because at that time because we can do an INR in the morning, and in the morning if you do an INR, if there is any abnormality, we can adjust the dose in the evening also. Sir.
Thank you.
Another issue that everyone should get into mind that during use of warfarin or heparin or enoxaparin during pregnancy, this is needed for long-term use, and in that case, you should prescribe the patient with adequate osteoporosis prophylaxis. This heparin or warfarin or even low molecular weight heparin can precipitate osteoporosis or favor osteoporosis. So appropriate osteoporosis prophylaxis should be given.
Thank you, Dr. Faisal, for your nice presentation. While I was listening, your presentation was very good. But you should put some put references in each slide. I think you put references after the end of your presentation. But this is not the presentation. Should not be presentation. Each slide should have an reference that audience should the slide will be palatable easily when audience will see a reference in each slide. Otherwise, your presentation is very good. যে তুমি এই যে স্পাইনাক বললা, লেটুস বললা, ব্রোকলি বললা, তুমি এগুলা একটু বাংলায় বলো তো। আমাদের দেশের রোগীরা তো মানে অরফারিন তো মানে আমরা অনেক মানে অশিক্ষিত মানুষরা পায় যারা এগুলো বুঝবে না। বাংলায় কি কি শাক খাইতে বলবা না, কি কি প্রিকশন নিতে হবে, বাংলায় বলো তো।
স্যার স্যার আমি তাদেরকে মানা করব ফুলকপি, বাঁধাকপি, তারপরে মাটির নিচের যে ফলগুলো আছে সেগুলো কম খাওয়ার জন্য স্যার। তারপরে আমি তাদেরকে বলবো যদি আপনাদের স্যার লেটুস পাতা, তো স্যার বাংলাতে লেটুস পাতাই বলা হয়। জি স্যার। আর এছাড়া স্যার না স্যার খাবে না স্যার, এগুলো বলবো স্যার।
মাটির নিচে আলু থাকে, আলু খাবে?
না স্যার, মাটির নিচের খাবার আলু এগুলো খেতে পারবে না স্যার, এগুলো খেলে তার স্যার ওয়ারফেরিন
খাবে
টক্সিসিটি।
কি বলো?
কে বলছে
খাবে
আলু
কি
খাওয়াতে
তাহলে?
কোনো সমস্যা আছে? কে বলছে? কোন হাদিস আছে?
আলুতে কোনো সমস্যা নাই,
আলুতে কোনো সমস্যা নাই।
আলু কাণ্ড
সহজ গাইডলাইন হচ্ছে
জি স্যার,
ফুলকপি, বাঁধাকপি, সবুজ শাকসবজি খাবেন না, এই হচ্ছে সহজ কথা।
জি স্যার, ঠিক আছে।
কয়টার নাম বলবো?
তবু এটাই
শাক, পালং শাক, এগুলো বলার চেয়ে এক কথায় হচ্ছে এইটুকু।
আচ্ছা, আমাদের খাবার জিনিসের মধ্যে যেগুলি আমরা মানে সুপার কমন ডায়েট, যেটা বলে ফেললো সবাই গ্রিন ভেজিটেবলস, সাথে যেটা আমরা বলবো, যেটা আমি ইউজ করি, যেটা আলম ইজ ভেরি মানে ইজ ভেরি রিলেভেন্ট, প্রশ্নটা করলো যে সয়াবিন, মানে সয়াবিন অয়েল এবং সয়াবিনের অয়েল যেটা, এটাকে খাবো না আমরা, এটার সাথে অ্যাড হবে, যেটা আমরা কমন ইউজ করি। আর যেটা বললো মাটির নিচে নিয়ে কোনো সমস্যা নাই, হ্যাঁ। আর বিশেষ করে শাকের মধ্যে সবচেয়ে যেটাকে বলা হয় সেই স্পিনাচ, অর্থাৎ আমাদের পালং শাকটা একবারে মানে এটা আমার খুব আমাদের প্রিয় সবার, এই শাকটা খাওয়া যাবে না। এটা হলো সবচেয়ে বেশি ভিটামিন কে এনরিচ হয় সবচেয়ে বেশি, এই জন্য এটা খাওয়া যাবে না। ওকে। আর সবই। আর আরেকটা জিনিস হলো, যারা আমাদের বাচ্চারা যারা এখন তো তারা 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 তখন ফাস্ট ফুড খাচ্ছে তারা, তো এদের ক্ষেত্রে যেটা বলতে হবে, তারা যেন মায়োনেজ এবং কোলস্লো, এই দুইটা কিন্তু খুব কমন আইটেম আমাদের, তাই না? এগুলি যেন তারা অ্যাভয়েড করে, তারা যদি খেয়েও থাকে, কারণ সব মিট কিন্তু মিট অ্যালাউ বলছে, ফিশ অ্যালাউ বলছে, অর্থাৎ সাথে কিন্তু এগুলি খাওয়া যাবে না। দে শুড নট টেক অল দিস additives along with their diet of foods. Okay?
Yes, sir. Yes.
Thank you.
Can I make a comment?
Yes, you can.
This is Dr. Bashar.
Yes, you can.
I'd like to thank Dr. Faisal today for his excellent presentation. He put together a lot of data actually, and I really felt that this topic needed to be brought back into discussion because there's so much going on regarding anticoagulation in our patients. We all have the same issue. The cardiologists, the cardiac surgeons, the vascular surgeons, we all have the same issue of anticoagulation in our patient population. So it is never a waste bringing these type of topics back into a discussion from time to time. So I think I would like to also thank Dr. Bari, Sajidul Bari, and the people who made decisions about bringing this back, because this is very, very important and should be repeated every few months, if not more frequently. I think Dr. Monor will also agree with me because this is really, really important. Thing is, we have really accumulating evidences, experiences with using anticoagulants of different forms. Recently, we had very peculiar experiences, like patient presenting with batohematoma, large batohematoma. The reason being, this patient was getting warfarin. At the same time, he was undergoing some sort of physiotherapy that actually took him to a physiotherapist who inflicted some sort of injury, like he was doing some sort of massaging over the gluteal area, back of the thigh. And this little, I don't think that was such a big trauma, but this little trauma resulted in a huge batohematoma that brought him to the emergency department of a hospital. So this is one word of caution to let everybody know that this sort of things can also happen. And when the INR was measured, it was more than 8. So bringing these evidences together, I think we all have a point, being very, very careful dealing with anticoagulants, particularly warfarin, and doing or taking the patient through a meticulous monitoring of INR rather than forgetting. This patient was from a very highly educated section of the community, and he was not doing his or measuring his INR for 2 years, and the reason being COVID. So I think on the COVID restrictions, but this is not acceptable. When you are taking anticoagulant like warfarin, there is no excuse that you won't measure your INR for any reason whatsoever. That's not acceptable. So if that happens, these are the kind of catastrophes that you are likely to end up with. So being cautious is very, very important with all anticoagulants. Warfarin is at the top of all that, I believe. Thank you very much.
Thank you, sir.
I want to make a comment regarding indication of warfarin. In my observation, day by day, the indication is warfarin is spectrum of indication of warfarin is being narrowing in my observation. As we know that there are few indications only we can indication of warfarin is that in valvular heart disease cases, moderate to severe mitral stenosis, and in prosthetic valves. And there are some recent data also that in bioprosthetic valves, the recent data suggested that NOAC is equally effective in terms of prevention of bleeding as well as prevention of thromboembolism in bioprosthetic material. So few will not be honored if you see in near future that in bioprosthetic valve NOAC is indicated rather than warfarin. But the thing is that in our condition, there are two ways. One is that it is cheaper that we can use for all patients, but INR is required to monitoring. This is another point. Rather than the DOAC and NOAC, it is most costly, but its benefit is that INR is not required to monitor. So still in our country, warfarin is preferable when it is indicated. But in future, we don't know what will be happen in case of warfarin indication. So this is my observation. Thank you.
I am in the same opinion with you that warfarin is a double-edged sword. We cannot avoid this, but at the same time, it may cause so many troubles. If the dose is subtherapeutic, it will not work, and the dose is supratherapeutic, it will cause harm. And this is very difficult to maintain the narrow therapeutic range. And even the quality of INR estimation in Bangladesh may not be up to the mark in many places. And this is another issue. And even some protocols are in pipeline that even in moderate to severe mitral stenosis and even in mechanical valves, the newer anticoagulants are being tried. So in future, I think warfarin will just secure its place in history, and it may even be used on the rat killer, or may not be rat killer, but nowadays just as a rat killer, warfarin is no more in use. Just zinc phosphide is used. So it may place its place is just in history in future. Now the Faisal.
Yes, sir.
Can you explain what is INR?
Sir, INR. In case of INR, we usually measures the prothrombin time of the patient and the prothrombin time of the standard prothrombin time of standard. Between this prothrombin time of patient and the prothrombin time of standard prothrombin time, this is ratio. This is the ratio of INR is the international normalized ratio of patient prothrombin time and the standard prothrombin time. In patient prothrombin time is divided by standard prothrombin time, and this INR usually measures according to the
Who has defined the standard just thromboplastin? Which is the authority?
Sir, it actually varies from.
No. Can anyone explain? Any student?
Sir, it is the ratio between standard prothrombin time and tested prothrombin time, and there is a sensitivity index. But sir, I couldn't mention the exact name of the authority, sir.
Okay. But this is nothing but a sort of standardization. You know that a vital reagent that is used during prothrombin time estimation is thromboplastin. And this thromboplastin is a biological agent. This thromboplastin may have got different properties according to the manufacturer and from lab to lab. This is an issue, and it will ultimately lead to differences in the estimation of the ratio between patient prothrombin time and the standard prothrombin time.
Yes,
to make this in a harmony, WHO just came into action. Ultimately, they just gave a standard according to whom ultimately thromboplastin reagent has to be manufactured. And this WHO defined thermoplastin is taken as the standard thermoplastin, and using this, the standard prothrombin time is measured, and patient's prothrombin time is compared to this. A ratio is calculated, and ultimately this is the INR.
Thank you, sir. Thank you, sir.
Thank you, fellows and faculties. We are nearly 9:30, so we can conclude the session. Thank you for your contributions.
Thank you, sir. Thank you.